Pushpa. Naresh?
Yes, sir.
Vijaya?
Sir.
No, no.
Good
Pankaj
evening,
is
sir.
frozen, I think.
Pankaj is freeze, sir. I think the signal issue.
Oh,
Vijay,
Yeah,
yes.
good evening, sir.
Good evening, sir.
yeah, yeah. So I'm just trying to get this thing. One good news for all of you who are talking is that you're all going to get 2 more minutes extra because Pushpa is sick and she just messaged that she cannot come. She has got COVID. So suddenly all this. So Naresh,
Sir.
you don't need to go jet speed. It's okay. 2 minutes, Vijay, but don't take too long, huh?
Sir, you will finish up, sir. On time, sir.
On time, on time. Yeah, then we can have a lot of discussion and other things. Hi,
Good evening, sir.
Pankaj is back, sir. Pankaj is back.
hi, Ankur. How are you? Pankaj is back.
Sir. Good, sir. Good to see you, sir.
Yeah, yeah.
Hi,
Pankaj,
Ankur.
still we are still in the good memories of Rishikesh, man.
Thanks, Rock.
It was really good. It was nice. So
Meeting or post-meeting memories, sir.
We hope to host you in 2028 again.
yeah, that's decided.
We have bid for it, and it is up to the chair people in ASSI.
Yeah, yeah. I think it should be all right, no? I think most of them will. The other one is Bombay or Delhi? I mean, Delhi is with you.
Yes,
The other
Delhi,
one,
and we are bidding
Yeah,
together.
we are together, sir.
oh, very good, Ankur. So you both are big giants, man. Who is your competitor?
So Navi Mumbai.
Navi Mumbai. But
Yes, sir.
ICSS has to be somewhere outside the big cities, no? That's
Uh,
actually the plan. Navi Mumbai, you can't take it as a. Uh,
so I think we've already won it, Ankur.
Yeah, yeah, I know.
I
Well,
can I can definitely talk about it, surely, if there is something there. Because the idea of ICS was two things. One is that ASSICON time was occupied by ICS. I started in when was it? Very, very long ago, 1998 or something like that. For two reasons. One is we thought that we can bring in foreign faculties, and that gave us the opportunity to liaise with, like, first 4 years was with European Spine, then it became JSSR, like that. Second is we didn't want that rigid monopoly, very dichotomized. Like ASSICON has everything, First day has to be presidential lecture, then all this. So there was very little leverage for innovative modeling. So we wanted that. And third was we said it has to go through smaller cities. So if you are putting up something, then I will put all these 3 points, no problem. So Pankaj will get me a good dinner when I come to Rishikesh again. Yeah.
Done thing, bro.
Yeah. Basu is comes, but don't tell Basu what we were talking about.
Good evening, sir.
Good evening, Basu. Basu, you make me
Sir,
feel very lazy whenever I see you in operating theatre cap.
no, I just finished. I only operate 3 days a week, sir. Not like you. I don't operate 5 days a week.
Yeah.
I only operate 3 days a week, Monday, Wednesday, Friday.
Yeah, me also. 3 days only. Basu, we were talking about this ICSS.
Yes, sir.
Initially we were planning that it should be in not in major cities, isn't it?
Yes, yes.
Ah,
Sorry, sir. We are live now, sir. Actually.
okay.
Yeah.
Like. So, good evening to all of you. This is the second in the series of the ASSI Focus Group webinars, and the second on the series from the group on infections. So I should first thank and congratulate our past president, Dr. Basu, for making this happen and also setting up of this. Initially, we were planning that it should be in not in major cities, isn't it?
Yes, yes.
Yeah. So are we live?
Yes, yes.
Sir, we are live right now.
Yeah. So as I was saying, we are. This is the second in the series of the ASSI focus group webinars, and the second on the series from the group on infections. So I should first thank and congratulate our past president, Dr. Basu, for envisaging and thinking about these focus groups, which I'm sure over the next few years will not only look at academics but also on focused research. And this is the second of the webinars on infection. And we had an excellent webinar on spinal tuberculosis a couple of weeks ago. Today, we will concentrate on postoperative spinal infections. And we have a series of very good lecture topics and also eminent speakers with us. Dr. Pushpa is unfortunately not able to join us, and so that 10 minutes will be shared by the other speakers. And I would hand it over to Pankaj for moderating this session. Over to you, Pankaj.
Thanks, Prof. Rajashekharan. So let's begin this ASSI study group on infection. This time we will be discussing majorly on post-operative spine infection. Let me call upon first speaker, Dr. Vijay Kamath, who's going to talk on risk stratification and patient-specific risk factors. Over to you, Vijay.
I'm just trying to set slideshow. Yeah, good evening, everyone, and thank you to the ASSI for this opportunity to be part of this webinar. Now, surgical side and spine surgeries have been progressively. Sorry, hello? Can you hear me?
Yes, sir. Yes. Sir.
Yeah, sorry. Yeah, thank you for giving me the opportunity to be part of the webinar on risk stratification and postoperative spine infections. Now, spine surgeries have been progressively increasing in numbers, and fusions are up almost 70% in the last 10 years. With increasing number of procedures, there's an increased number of postoperative complications, and chief among them is surgical site infections, with a rate ranging from 0.7 to 12%. And this depends on the diagnosis, the procedure, and the studied population. The burden of SSI is tremendous, and it's a huge amount of morbidity for the patient because of increased hospital stay, prolonged antibiotic administration, and sometimes repeated surgeries. It also costs a lot on the healthcare system. Occasionally, it could lead to mortality of the patient. And of course, there's misery to the surgeon, and unfortunately, there's no literature on that available. The solution is, well, prevention. Prevention starts with understanding the problem. And hence, we need to know the risk factors that predispose us to SSIs. There are patient-related factors, which are mainly preoperative, and provider-related, which are intra and post-operative. And among these, there are certain which are modifiable and certain which are not modifiable. Now, let's have a look at the risk factors that are available. Now, I've basically taken this from a multitude of literature. And of course, it's important to understand that most of it is from single institution studies. Part of it is from meta-analysis. And there's a huge amount of conflicting data that's available. However, I put this all down here. And I think most of us in clinical practice will understand that a lot of these do affect the chances of developing an SSI. Patient factors that we have to look at are the age, sex, smoking, diabetes, increased BMI, history of a previous spinal surgery, and a high ASA classification. And the other factors being hypoalbuminemia, chronic cardiac, renal, or liver diseases, and skin disorders, essentially all predisposing the patients to a higher chance of infection because of low immunity. Also, things like steroid use, immunosuppressive drugs can predispose patients. I'm not going to be talking about the provider factors because that's not part of the topic for today. When we look at age, There's no definitive data, but there is a study that's been done which takes a cutoff at 54, saying that when the age is higher than 54, there's a significant effect on the risk of SSI. And this is because of declining systemic immunoreactivity and other age-dependent biological factors. As far as sex is concerned, again, there's conflicting data, but there is a large study which was done on about 60,000 patients, which said that female sex was an independent factor for postoperative wound infection in patients undergoing spinal surgeries. And there's another similar study on 3,000 patients done by Kutum Selbis, who said that 66% of the patients with SSI were female. But it's important to understand that studies that have been done, which have taken multiple variables, have shown that males can have a higher chance of infection, especially if they were smoking and if it was a revision spinal surgery. As far as BMI is concerned, again, the literature is controversial, but most literature says that a BMI greater than 30 has a higher incidence of SSI. The reason for this is because they have a large mass of subcutaneous adipose tissue, which requires strong retraction forces. This leads to reduced tissue perfusion and necrosis, and this becomes an ideal bed for bacterial pathogens to colonize and give rise to infection. Now, as far as diabetes is concerned, again, some show that diabetes is not a risk factor, but most of literature does show that it is a risk factor to be considered. Now, it's important to understand that there is no definitive predictive cutoff value for either HbA1c or blood glucose that has been shown to increase the incidence of infection. How does diabetes cause infection, predispose to infection? That's primarily because it causes diabetic microangiopathy, leading to decreased local tissue perfusion. Necrotic tissue is a good bed for colonization of pathogens. And also there's impaired granulocyte function because of the hypoperfusion in that region. There was a large study on 5,000 patients done by Cancini et al. On single-level lumbar decompressions. And what they did find was that patients with a HbA1c level of greater than 7.5 had nearly 3 times greater risk of SSI. However, it's important to understand that there is no guidelines given on what the ideal management of diabetes should be prior to this. Some say that a preoperative optimization of HbA1c to less than 7 would be ideal. And others say the glycemic control in the 2 weeks prior to surgery is of more importance. Smoking, yes, smoking has been shown in many studies to be a risk factor. The study by Wong et al. Showed in a meta-analysis of 7,200 patients that patients who quit smoking a month before surgery decreased the risk of SSI by almost 50%. However, it also showed that ex-smokers still had a greater risk of wound complication compared to never smokers. As far as hypoalbuminemia is concerned, it is a significant risk factor for SSI. That's because of poor immunity and poor wound healing. And hence, it's always preferable to postpone surgery till the albumin level is optimized. As far as the ASSI classification is concerned, a study by Somani et al. On 5,800 patients showed that there was a significant linear relationship in wound complications in the ASSI class, going from 0.6 in class 1 to almost about 4.4% in class 5. Now that we've looked at the risk factors that are available, it's important to understand that all of these studies give you the odds ratio and the relative risks of a given variable to help quantify risk factors for infection. However, looking at these individual variables does not help you to calculate the expected patient-specific risk profile, and hence it does not help in patient counseling. It's very important to understand that we should calculate the patient's individual risk profile, in this case, infection percentages. And there are risk assessment tools that have been developed that consider the confounding variables and several other parameters and help to give us the overall risk of infection. This becomes very important because it helps us to counsel a patient when they're going for surgery. It allows us to identify high-risk patients and institute measures either pre, intra, and post-operatively that could help to reduce the chances of infection. Case and example would be glycemic control, improvement of the albumin levels preoperatively. We could reconsider the surgical procedures in patients which are very high risk for surgery. We could go in for smaller surgeries. Also, it helps in selecting appropriate patients for these expensive infection prevention strategies. Now, patients who are high risk, we may need to think in terms of giving them higher antibiotics and not the routine prescribed antibiotics for prophylaxis. Also, we can optimize surgical procedures, getting in patients' team to operate using minimally invasive techniques that could help to optimize, and also using things like antibiotic sutures. But all these are expensive, and hence by profiling these patients, we can optimize the usage of these facilities. Now, what are the predictive models that are available? There are basically three different types of models. One are equation-based, the other one gives a stratified risk, and the last are web-based applications. Now, I can't get into how each one of these have been developed, but essentially most of them have been single institution based. They have looked at the number of patients operated, their rates of infection, done univariate analysis, found a list of factors, use that in then for a multivariate analysis, and then come up with the a set of risk factors that predispose you to infection. So let's look at look at the first one, which gives us a stratified risk. This is a study done by Naba et al. I won't get into the details of this, but essentially what they did after multivariate analysis was find that blood loss, the presence of diabetes, emergency surgery, albumin less than 3.2, and the presence of skin disease all predisposed to a high rate of infection. Using mathematical modeling, they gave them scores of 1, 2, and 3 based on what they found was relevant. And when you had to add up these scores, and this gave you a risk classification. If you had a total score of less than 0 to 1, you had an infection rate of about approximately 2.9%. And if your score was more than 3, it raised your infection incidence to almost about 38%. A similar study, which was done by Stepan et al., found 11 factors that were contributory. And they also gave a scoring system to this. They gave each factor a score of 1. And when you totaled it up, it put you into grades of low, intermediate, high, and extremely high risk based on your score, with the percentage of SSI raise going from 1% all the way up to 66% in patients who had scores of greater than 8. In other words, 8 risk factors. Now, the study by Clemens et al. Was done, and he looked at based on an equation. Again, the risk factors that he found were 7: age, arrhythmias, BMI, chronic liver disease, diabetes mellitus, IHD, and systemic immune disease. And he gave each one of these factors a score of 0 or 1, depending on whether the factor was present or not in the patient. And it was an 8-point categorical scale. You added up the scores, and if you had a score of 0, you had a chance of 1.6% of infection. And if it went up to greater than 4, it gave you a possibility of having an infection of up to 20%. A similar study by Lubelsky et al. Was done, and he also looked at taking the surgical invasiveness of the procedure, which a lot of other studies did not do in detail. And this is a scoring system that is available there online very easily. From his multivariate regression analysis, they found that female sex, BMI, smoking, diabetes, the ASA classical invasiveness were predictors of infection. And they developed a web-based analysis, and this is available online. It's called the wound infection calculator. Now, for example, in this patient, I've taken a male patient with a BMI of 31, a smoker and diabetic, with the ASA grade 2. We're doing a 7-level fusion, which is putting 14 screws. We're doing 4-level laminectomy and say 3 interbody fusions. Of course, you can look at Schwab's osteotomies as well. But in this particular patient, you can see the risk of infection has been calculated at 17%. So by changing these values, it can give you a pretty good analysis of what the chances of infection in your patient is. Another similar study, which was done by Lee et al. From Washington University, where he called it the Spine Sage, again available online. You have to put in the risk factors that are available, including the age, the diagnosis, the levels of surgery. And here I've taken a 65-year-old patient with a male and with diabetes who's undergoing a revision spine surgery. He's got a BMI greater than 30. It's a degenerative in the lumbosacral spine. And when I generate it, it gives me the list of medical complications, infections, as well as dural tears. Here in this slide, it's giving me the chance of major complication and the chance of all complications. Now, how do we decide which one to use here? We look at the level of surgical invasiveness. So in this patient, if I was doing a TLIF at L4-5, it would give me a surgical invasiveness of 8. So I'd go here and between 5 and 8, so it gives me a total major complications of about 4% and 18% chance of overall complications. When it came to infections, again, we'd look at, say, about 11% chance, because this patient was a diabetic, aged, and is undergoing a revision spinal surgery. So his chances of infection here would be 11%. Of course, on changing the factors, you get a different percentage of infection. Another one done by Hirsch et al. looked at patients, but here he looked at patients who had undergone surgery for metastasis only. He didn't take into consideration other patients. And they found that a higher Charleston comorbidity index, a Karnofsky performance index score of less than 70, a revision surgery, and increased incision length, and in effect, more number of levels of surgery would give you a higher rate of chance of infection. And this again is available online. So here we've taken a patient with peripheral vascular disease, a pulmonary disease, diabetic but no end organ damage, and doing with normal platelets and doing 6 levels of fusion. And we can see that our rate of infection here is about 10%, with wound complications being around 12%. So as you can see, there are different models that are available. It's important to understand that when you look at all these models, each of them use different variables. And the reason for that is because most of these are based on single institutional studies. So they looked at their stats and looked, and hence these their data cannot be generalized. Also, these studies have taken variable definitions of infection. Some have taken both superficial and deep infection. Some have taken only deep infections, and some have taken deep infections that have had to be reoperative only. Again, different pathologies. For example, some have taken only degenerative, some have taken all pathologies. Some, for example, like the Hirsch study, has taken only metastasis. Some other studies have looked at various regions of the spine. For example, some have taken only the lumbosacral, some thoracolumbar, and some the whole spine. And importantly, different definitions of invasiveness. Again, some studies have not taken invasiveness into consideration, and some have taken a detailed level of invasiveness. And this is the reason why we've got so many different models, each one taking in different variables to be considered for their risk stratification. So to summarize, surgical site infection is a devastating complication with a rate of 0.7 to 12%. There are many different risk factors, patient and provider related. There is conflicting literature on variables that predict SSI, but there are some which are rather common throughout. The patient-related risk factors could be modifiable and non-modifiable. It is incumbent upon us as physicians to make sure that the modifiable ones can be modified to whatever extent possible without compromising the patient. And also, risk stratification models are available to assess the overall risk of infection. These are variable and not perfect. However, they're still very useful for patient-specific profiling. And this becomes really important when it comes to patient counseling, because it helps us to get the patient involved and understand what they're in for, and also helps us to institute both pre, intra, and post-operative functions that can help us to reduce the overall infection. Thank you.
Thank you, Dr. Vijay. It was a lucid and comprehensive talk. I know this is a bit too complicated for stratifying the risk of SSI. I am really glad that you made a very good presentation on this. Any questions for Dr. Vijay Kamath? I just want to ask question to senior faculties here. What all I understand there are modifiable and non-modifiable things. I just want to know what precautions everyone takes when you plan an elective surgery. Professor Raja.
Yeah, so Pankaj, I think these all are pretty good for us to, just like when you're going fast in a road, they say this is an accident prone zone, and then you tend to become more careful. So it also gives you a possibility to counsel the patient on what needs to be done. It's a good medical legal backup also, that you are operating on a high risk patient, and the surgical procedure that has a higher post-operative infection, I think it gives you a backup. So there are modifiable factors and non-modifiable factors. So nowadays we are tending to err towards safety and correct all the modifying factors. Before, if the HbA1c was around 8, sometimes we admitted them. After 2 days, we operated. Now we have actually a very good discussion with the patient saying, would they like to go back, and then correct it and come after some time. Smokers also, now we are a little bit more strict than what we were before. And obesity, Now there is a growing tendency to give these weekly injections, and we have started doing it now for morbidly obese. Even this morning, one patient was 142 kg from Oman. We said, okay, have these injections for some time and let's see what happens. 25 kilos less from 148 kg is really a big 25 kgs less. So these, I think we have to take this a little bit more seriously so that the infection rate comes down.
Dr. Basu or Dr. Chala, I just want to know that do you see SSI more common with lumbar surgeries when compared to cervical or dorsal spine? Though we talked about TLEFs and other number of surgeries, number of levels we operate, but in my practice, I've seen that lumbar spine, especially in degen lumbar spine, I tend to have more SSI when compared to a cervical spine or a dorsal spine. And same is in spinal tuberculosis. I've seen spinal tuberculosis patient landing up. We did publish this also that they are slightly immunocompromised when compared to normal people, and they are at more risk of developing surgical site infection.
Yeah, so Dr. Pankaj, I absolutely agree with you that I was just looking at our data, just making this presentation, and the infection rates that we have got is much more. I cannot see that there are any infections in the anterior cervical. Definitely, there is very few infections in anterior cervical. Even posterior cervical, our infection rate is very less. But I have been seeing a lot of infections in the lumbar spine, especially instrumented lumbar spines. As far as decompressions and discectomies are concerned, I think because everything has gone minimally invasive, the rate of infections for discectomy has gone down, but instrumented infections have definitely gone. I'm seeing a lot of these infections. So I agree on that, that lumbar with instrumentation has a higher rate of infection compared to the simple decompressions and discectomies.
Okay. I
Same
don't
with me,
see any
Pankaj.
questions.
It's always lumbar spine, which is much more because it is proximity to the uh, urine and stool. And in our cases, I have found that though in textbooks it's written that in Staph aureus is the commonest, in our series we have coliforms, and enterococcus, and pseudomonas, and klebsiella. They are much more common than Staph aureus, possibly because of the proximity to the anal canal and soakage from urine and stool. The other thing which, before going on to the next lecture, Pankaj, I just want to make a point here that risk stratification or a proper preoperative assessment of all elective cases in spine surgery is so important. In Professor Rajshekharan's institute, also have visited person who've seen that most of the patients, though they want to walk into the hospital and get admitted for surgery, at least in my setup, they just cannot. They have to see an anesthetist, get a proper preoperative checkup, get a date for surgery. All elective surgeries should be preoperatively checked up, optimized, and then only that actually decreases the complication rate, including the infection a lot.
Excellent. Sir, at the same moment, I would just want to ask, in the interest of the audience, um, how critical is timeout and those pre-op steps which become important to avoid SSI for you?
Professor Rajshekharan will answer that. You're muted.
I think time out is has more benefits of many things, of not operating on the wrong side and doing the right procedure, right levels. All that is very important. But I think the one of the most important things in the pre-op room is the duration at which the timing of antibiotics. So I think this is very critical. And however hard you try to enforce the correct timing, we have found it is so difficult. There are so many reasons why this is done, because the patient comes a little late, the surgeon is in a hurry, or the patient has been given some other thing, or when the antibiotic timing is not given at the right time, at least in 30% of the patients. So more than timeout is important, that is there, but timing of antibiotics is extremely important. Preparation of the skin, whether you're going to give them a chlorhexidine or some latest preparations for preparation of the skin the previous day, whether they are going to have an antiseptic shower, all this definitely will go. Very, very important. And also handling of dissection, I mean, whether you dissect properly, how well you handle the muscles, how much the thick muscles are retracted for a long time, and whether the tissues are left to dry. So there is a lot of subtleties in your surgical technique also, which matters, which cannot be defined in all these scores. How good the surgeon or his assistant is, and how good the dissection is, all this should be very important. Intraoperative hypotension is another important thing which we don't talk about too much. But in major surgeries, if the patient has not been transfused properly, and there's a lot of modern techniques where they don't transfuse blood. They transfuse only packed cells and FFP and this thing. But that doesn't do as good as giving whole blood. There is a lot of plus and minus towards this. But if they are not adequately transfused, if they have an intraoperative hypotension, if the surgeon's dissection is bad, handling of tissues is bad, all these are also very, very important. And timing of antibiotics before surgery.
Thank you, Prof. I just want to add one more thing here, which goes unnoticed is underdosing. So the dosage of antibiotics become very crucial. It should be as per the weight of the patient. That has
Yeah.
to be question here in the chat box. Is there any repeating antibiotic in longer surgeries? In my practice, I repeated the procedure is going more than 3 hours. So what is Professor Basu or Dr. Chahala practice?
4 hours for us.
It's 3 hours for us.
4 hours for you? Okay.
3 hours for us.
Okay.
I think that
So
would also depend
approximately
on the
the answer is
antibiotic that's being used.
come again.
I said I think that would also depend on the antibiotic being used. Like if cefuroxime or cephalexin, which is the one that commonly used, that will be every 3 hours. However, in certain cases, if the patient's sensitive to that antibiotic, and you're saying you're using vancomycin or some other antibiotic, it would depend on the half-life. But I also agree with you that quite often it's the underdosage which happens, and that can predispose the patient to antibiotics. I'm sorry, to infection.
Okay. Thank you. Thank you, everyone. Let's move to next talk. And I invite Dr. Amit Jhala, who's going to talk about one of the, I would say, complications which comes under SSI, which is post-op discitis.
Amit, you can share your screen.
Hello.
Amit, we can hear you. Go on.
Okay, fine. So after coming to the risk stratification, the first important surgery that we have as a routine spine surgeon is the disc prolapse surgery. And if you see, this is a patient who had a left lower limb pain for about 3 months, which was not relieved by conservative treatment. And whenever such a patient comes to us, we feel that it's one of the easiest case that somebody can operate, and it's bread and butter for a spine surgeon. And the microdiscectomy was done for this patient. Now, what happened is that the patient was happy for a few days, but there was a persistent disabling back pain, had to take around the clock analgesics. The radicular pain had subsided or decreased, but there was no fever, constitutional symptoms. The wound was okay, there was no inflammatory signs. And the big question here asked by to everyone is whether it's a poor patient pain tolerance because the back pain is there, or is it more than a longer surgical recovery time, or is there any residual fragment or recurrent disc which has come up, or is patient is psychologically unstable as they are always apprehensive about the spine surgery. And there is a surgeon's dilemma when the patient comes back with less radicular pain, but the back pain is more. And we try to overlook the symptoms and reassure ourselves because we never find problems in our own surgeries. So whether to start a steroids in such case or not, the X-rays we take it are netted, they don't show anything, and the lab investigations usually if we do we get a high counts, high ESR and CRP. Anyways, they are going to be there raised in the post-operative patients. So to get the diagnosis of a post-operative discitis, you require a high level of suspicions, and earlier the better, and that's very, very important. So if you see the incidence of the post-operative discitis, it is about 20 to 30% of all the pyogenic spondylodiscitis. And if we compare the infection rates of different discectomy techniques, and we can see this chart that if you go for an endoscopic or a tubular discectomy, the rate of infection is quite less compared to the conventional open or a micro discectomy. Of course, it comes to less than 1% if it's an endoscopic or tubular ones. And this is what nowadays everyone is practicing is a micro discectomy or a tubular discectomy. Now, coming to why the infection occurs, and this was very well described in the previous lecture, but the two important factors are there is a direct inoculation of the organism through the skin flora and the exposure of the wound or the time of exposure of the wound to the environment. So that is the first factor that comes for the pathogenesis. And the other important factor is the hematogenous, which I think we discussed also previously, that there can be a distant infection or most common that we see is a urinary tract infection, and that has to be screened in all the patients before we go for the surgery. Uh, the case of aseptic discitis, which is sometimes controversial because we are not able to sometimes identify the organism. And sometimes what happens is we just continue the antibiotic and there is a self-resolution of the infection. And if we see later on, the patient has got a completely collapsed space. And that's a controversial whether we are able to find out the infection, the real pathogen in these patients or not. As was discussed about the microbiology, usually we are able to isolate the organisms in around 40 to 70% of the cases. And discitis is mostly a monobacterial infection. The gram positive is more common, though it was around 80%, but now the gram positive infections have come down. Staph aureus is 50%. We see a lot of epidermidis and MRSA also. But the recent trend, as was pointed out before, is the gram negative, and that too the multi-drug resistant gram negative, especially E. coli, Pseudomonas, and Klebsiella are also common. And rarely there are fungal, which we have also seen in our clinical practice. If we see this patient now, clinical picture is very, very important, and that's where your clinical acumen takes to for the early diagnosis. Usually, these patients have a lag period for a few days to about 10 weeks, but and the back pain is gradually increasing. Usually, the patient should have a gradually decreasing back pain, but here the patients will have a gradually increasing back pain, and that should click in your mind that this patient might have the infection. The patient will tell that they are relieved of the leg pain because you have really removed the compression there. Patient will come with an acute unrelenting back pain with a muscle spasm, and that should click in mind that you are having this patient is having spondylodiscitis. The patient will not be able to bend forwards. There will be pseudo-Gower sign, which will be positive. And wounds are some because we are all minimally invasive. The wounds may be normal, and you may not see the wound. The skin may heal, but the infection may spread inside. And you can see this is one of the patient which was there in our. This is this is how the patient may come to us. In subacute or chronic cases, sometimes there is no diagnostic clue, and you may miss out on these spondylodiscitis patients. Coming to the hematological parameters, the WBC count and CRP are always raised in post-operative period. So, and the other important part is that we never get a CRP done in our preoperative investigation. So we don't know the baseline values. The other, and even in post-operative period, we are not getting the CRP. So once you suspect, then only we get the CRP done. But how much to rely on them in post-operative period? So always if the patient has got back pain which is increased, we should get the ESR and CRP done in these patients because they are going to help in the follow-up periods. Now, what are the diagnostic values of the ESR and CRP? And this is a very nice study. And usually the ESR peaked on the fourth day and they return to baseline within 3 weeks. The sensitivity and specificity is around 70%. And if you see the CRP, it peaked on the third day, but it will return back to baseline within 2 weeks. So these are investigations which are very important. But individually, they will give around 60 to 70% of time the clue. But if you have a rising values and serial measurements, the combined sensitivity increases to around 80 to 85% of these two investigations. Now there are other investigations that are there for discitis, and these are sometimes advised, but blood culture it does not it has no role in postoperative discitis. Procalcitonin also not useful for the diagnostic tool in these patients of spondylodiscitis. The other investigation that we may give to the patient is the X-rays. They usually have the diagnosis. It takes about 3 to 6 weeks time to have a destruction, and you cannot get in early phase of the patient where you don't get a destruction. This is a patient where after 3 weeks there was a end plate changes and end plate erosion which was seen. The CT scan will give better, but again, that again takes about 3 to 4 weeks time. So if you want to go for an earlier diagnosis, I think imaging studies are the best, and that best the imaging study that we have is an MRI, which will have a 93% specificity and 97% sensitivity. And if you suspect the postoperative discitis, then it's always better to do a post contrast study that will give much more. This is a post contrast study which will give the end plate changes and the erosions which are much more seen in post contrast compared to the normal. But in normal MRI, you will see in T1 and T2 a modic type 1 changes. So it's very important to differentiate the normal post-op MRI compared to the post-contrast. And if you see this is a normal post-op MRI, there is a high intensity in the disc, but the end plates are comparatively normal. But if you have post-contrast in a discitis patient, you will see a lot of signal changes surrounding edema, and this is where you can differentiate very well between the normal as well as a discitis. Coming to the management, it's very important for the management to identify the pathogen and to find out the sensitivity to that, which antibiotics and for how long it should be given, when to consider the operative intervention, and what type of intervention. I think these are the four questions that we need to know for the management of postoperative discitis. So to identify the pathogen, CT guidance, usually the CT guidance gives around 25 to 35 yield. It's not much of a value unless you have a good abscess inside. Otherwise, the best way is to do a open biopsy which gives a 90 to 100% positivity. But to do an open biopsy is a surgery which we actually want to prevent in these patients. And the next important method to find out the pathogen is an endoscopic debridement and sampling. I think this is one of the best way to find out which organism. It will give not only the sampling, good sampling, it will also, the culture yield is around 84.38% in this one of the study, which was there recently published. And PEDD may also improve the identification, but it will also reduce the pain. Usually these patients have a very severe pain, and once you just wash out the wound with the endoscopic debridement, the patients will be comfortable and you will also get the sample, and that's where the endoscopy comes in the picture in these patients. So now once you get the sample, and if you cannot find out what is going to happen you cannot find out from the culture, and you cannot cultivate the culture, then these are the very, very important and very helpful molecular diagnostic which we are using in such patients. It can detect the bacterial DNA even from the dead DNA, and therefore PCR will give actually it will identify what type of pathogen it is. It may not culture, but at least you will be able to know that which bacteria it is. The other important thing is that it has a rapid turnaround time, and it can identify any, if you have an NGS or next generation sequence, it can have virtually all potential pathogens which can be identified. So this investigation is very, very useful. If you get a sample and if you get a PCR, the only thing is the costing, which may be a little bit high, but it will give a good the identification of the pathogen. So now once you have identified the pathogen, the primary management in these patients who of the discardis is non-surgical. These patients can be treated by antibiotics, immobilization, and pain management, because pain is the main factor which is going to decide further how you are going to treat these patients. So immobilization is must. The antibiotic according to the sensitivity is must. So that's the first choice. So if you want to give an antibiotic to identify the pathogen, and once you have identified the pathogen, early starting of the antibiotics might give a good results with a non-operative management. But if the patient has increased pain, increased distraction, there is rising CRP, I think there is no other choice than to go for a surgical treatment. So coming to our main important conservative treatment, which antibiotics and for how long? So if you can identify the culture and sensitivity, you can give an antibiotic according to culture sensitivity. But if there is not identifiable pathogen, then you have to give an empirical broad spectrum antibiotic, which has a good penetration to the disc space. I think that's very, very important, that it has to have a good disc space penetration. The duration, the literature says, is 6 weeks and 6 weeks of IV and 6 weeks of oral. But what we follow is 3 weeks of IV and then check the practically whether the CRP has come down or not, and how the patient is having clinical, whether the pain has come down or not. And then we follow it up for the 3 weeks of oral. But this is all dependent on the further CRP measurements or the serial lab measurements. So coming to selection of antibiotics, if when the end plates are intact, it's very important that antibiotics should penetrate the disc space, and the positively charged antibiotics are much better compared to the negative charged molecules. And the antibiotics which can penetrate the nucleus pulposus are aminoglycosides, glycopeptides, clindamycins, and quinolones. So if you have no end plate changes and if you have picked it up early, I think you have to select from these antibiotics. But if you have the pathogens which may not be sensitive to these antibiotics, and if you want to use penicillins, cephalosporins, and meropenem, they do not penetrate the nucleus pulposus because they are negatively charged. So you might have to give a higher bolus, higher dosing, and a continuous therapy. So this also needs to be seen, that if you are using these antibiotics, you might have to give it for a longer time with a higher dosing. MRSA, of course, linezolid and vancomycin, they are our choice. But if there are end plate breached, supposing like if the end plate is already destroyed or you are doing a surgery, then all antibiotics are going to work because the channels are all open and the antibiotic can diffuse inside the disc space. So this is how you must do the selection of the antibiotics. Now, what are the results of the conservative treatment? Once you go for a conservative treatment, these results vary from 35 to 88%, and these are the different studies which have given different types of results. The crux of the whole study is that if you identify the pathology early, and if you start the antibiotics early, then these results are fine. But if it is not possible and if you give empirical, then these results may not be as what you want. The other important limitations of the conservative treatment is it gives a delayed pain relief. So the patient has got severe pain. They are not able to bear the pain till the antibiotics work for about 2 to 3 weeks. And you might have to give a prolonged antibiotic therapy, which may increase the antibiotic side effects. And that increases the hospital stay also. And therefore, though conservative treatment may be a good choice, early surgery is much more recommended in postoperative discitis. So this is a recent report on 2023, which is a systematic review and meta-analysis. The relapse rate or the failure rate of the conservative is around 21%, mortality is 13%. In average, it increases the 7 to 7.5 days of reduction in length of the hospital stay if you operate. And therefore, this recent articles also suggest that if the patient cannot tolerate pain, early surgery may give a better result. So now when to go for a surgery? When the patient has no relief in pain in spite of antibiotic treatment, maybe 2 to 3 weeks you wait, and then if the patient has no, you may go for a surgery. If there is persistent increase in CRP and ESR in spite of giving antibiotics, you may go for surgery. If the patient has a neurological deterioration, yes, definitely. And if there is a destruction, increasing destruction of the bone leading to either instability or kyphosis, then you might have to go for early surgery. So these are the 4 indications where you may think that you might go for surgery. Coming to the types of surgery, there are 3 things which are there. One is only debridement. Second is debridement with fixation and fusion, whether you can do it open or MIS, or you can do a transforaminal endoscopy under GA or local anesthesia. So debridement you can do if you find the infected wound very early, you can just go for a debridement. But if you have waited for the antibiotics and then you might have to go for the debridement and fixation and fusion. So if you see this, one of our patient which was operated for the same patient which I showed for a discectomy on the right side, and then patient had discitis, and then we operated sorry then we operated with a fixation and interbody grafting. uh, Usually you can definitely put a cage, but I usually put a graft, and I don't like to put a foreign body inside. That's my personal choice, though literature is definitely in favor of putting a cage or any stability structure there. But then this is after that the patient was absolutely fine and walking normally. So this is what gives that. Another patient, again a similar, there was a post-discectomy infection. This patient, the previous patient had a staph. This is a Pseudomonas, which was multi-drug resistant, debrided once, no improvement. And then this is the same procedure that we repeated, and this is a 1-year follow-up of the same patient. So debridement and fixation infusion gives a very nice result. Another patient,
Jhala sir, may I interrupt you? Can
yes,
we
yes.
close the talk?
Yeah, sure. It will just take few more slides, that's all. Okay. So this is a Staph aureus infection, and the same thing was done. I'll just this is one of the other approach. If this is a discitis, you can just go for a lateral approach, which is a direct approach. You can just directly debride and put in the either you can put a cage, as in this case that we put the cage, or you can just put the graft, iliac crest bone graft. So similarly, this if the distraction is more, then you might have to do anterior and posterior surgery, as in this case that we did. So that is a 6 months follow-up. So in active tuberculosis with a kyphosis, if there is a kyphosis, as you can see in this patient, there is a kyphosis and there was a lot of destruction. This also will require an anterior and posterior reconstruction, and that's an anterior and posterior reconstruction. There is definitely a role of endoscopy, which I will not go because I already talked about it in before. But in a high-risk patient, this was a high-risk patient where GA was not possible. We just did a transforaminal biopsy and debridement with a staphylococcus infection and then antibiotic therapy for these patients. So in management summary, infection is limited to the disc space. You may go for a conservative, or there is definitely a role of endoscopy if the infection is limited to disc space, which will give an early pain relief and early mobilization. If the infection extends to the retrodiscal, or there is an abscess or apical abscess, definitely you may go for a surgical debridement and fusion. But if there is a bony destruction and deformity, you may require an anterior reconstruction along with it. So high index of suspicion, clinical examination, value of investigations, MRI, and depending on the antibiotic, you may go for a conservative or the operative approach. Thank you very much.
Thank you, Dr. Jhala. Do we have any questions for him? I think we can proceed with next talk because we are running short of time now. Dr. Ankur Nanda is going to talk on role of instrumentation retention versus removal. I request everyone to stick to time. The time is 10 minutes for each.
Yeah. Thanks, Pankaj. Thanks for inviting me. And I would like to thank ASSI. I'd like to thank Rajshekhan sir, Srivastav sir, Pankaj for giving me this opportunity to speak on management strategies in spinal infections. And the big question is whether to retain the implants or not to retain. And we'll go through this probably one by one. So the objective of today's presentation is to not only get insight into why this implant question arises, what is the pathophysiology behind it, but at the same time to understand what is the clinical decision making, what should be the treatment protocol when we are removing and when we are not removing, what antibiotics to use, and who are your friends in this, and whom do you need to involve when you plan to sort of are your slides visible?
Yes, it's visible.
Yeah. Okay. Sorry. I think I switched windows in between. Yeah. So when you plan to do this, all right. So we know that the spinal fusions have increased quite a lot over the last few years. And as the spinal fusions have increased, the degenerative spine has increased, our longevity has increased, as Dr. Pankaj was pointing out, the rate of infection has also increased, especially in the degenerative lumbar spine. And it has a huge clinical impact because it not only causes a financial burden, it is also highly disabling to the patients. If you look at roughly available Indian statistics, which are not really proven, but there is anecdotal reports about it, the infection rate is anywhere between 2 to 12% in post-surgical implant-related infections. The cost easily reaches, when you get a proper post-operative infection, to around 8 to 15 lakhs. The patients spend much more time and the reoperation, much more time in the hospital, and the reoperation rate is almost 40 to 60%. So why is the implant associated infection different from any other? It's because we know that some of these bacteria, they are able to form a biofilm. The initial bacterial adhesion on the implant occurs as soon as within hours after surgery. And this biofilm is something which is something which protects the bacteria. It doesn't allow the antibiotics to, attack on these bacteria. And at the same time, it increases the antibiotic resistance by almost 1000-fold. At the same time, these bacterial cells are metabolically dormant and they are able to evade conventional treatment. So it becomes very fastidious. So Dr. Kamath had talked about the risk factors predisposing patients to spinal implant infections. We'll not sort of go into detail, but we need to understand clinically a key difference between early and delayed onset infections, because that will decide what our management strategy is going to be. So early acute infections are those which are happening within 4 weeks of surgery, and they are characterized by an acute response. So patient will have more dramatic clinical course, will have a fever, wound drainage, severe pain, and all the markers will be elevated. And this is the time when the biofilm is usually immature and is not well formed on the implants. And probably this is the critical window for early intervention. However, the late onset infections are a little different. They happen after more than 4 weeks post surgery, and their presentation is more indolent. There are subtle symptoms like persisting pain, implant loosening, sinus tract, feeling of unwell-being, and usually they are caused by low virulence organisms like Coagulus negative staphylococci. The clinical significance is that the biofilm by now has become quite mature and it has become fastidious and it is more difficult to get rid of. Again, there is diagnostic challenges in spinal implant infections. It ranges from clinical to radiological to laboratory. Clinically, when they develop a late onset infection, the patient may not have specific symptoms like high-grade fever. Laboratory limitations are also there because CRP and ASR, they lack specificity, and low-grade infections may not show much abnormalities in the lab. Imaging metallic implant artifacts, they confuse us with the edema, which you can see associated with infections, and becomes difficult to diagnose. So if you look at the laboratory markers, the sensitivity and specificity, even though CRP is quite sensitive, but it is not so specific. And as Dr. Jhala was pointing out, it can quickly normalize around 3 weeks, but the ESR continues to sort of be high around 6 to 12 weeks. So they do not really help us in delayed onset infections, and we're not sure whether this infection, which is an indolent infection in a late onset, is these parameters, will they be not necessarily be high. As I said, imaging modalities, even though CT scans can give us an excellent bony detail and also can help us in identifying loosening of implants, but they cannot tell us about the soft tissue. And that is where the role of MRI comes in. However, MRI is also fraught with metallic artifacts, and it is difficult to detect early infections because of the metal artifact. The FDG PET CT scans and the labeled leukocyte scans can help us in distinguishing aseptic inflammation from a pyogenic infection, but in many of the cases, it remains ambiguous as well. If you look at the common pathogens, most commonly it's the Staph aureus which affects. However, in Indian scenario, as Dr. Basu had rightly pointed out in the beginning of the webinar, that we see a lot of gram-negative organisms also who appear in the Indian population as the cause of surgical site infection. And what we have also seen is the fungal infections have also becoming more and more common in these isolates. And so many times we are missing these cultures to send. So it's very important that whenever we take a sample from the surgical site, the fungal samples are also sent. If we look at the resistance pattern in the Indian healthcare, it's changing every year, or so the prevalence of MRSA has increased quite a lot, and 40 to 60% of the Staph aureus isolated are methicillin resistant in tertiary centers. Now we have more and more ESBL producing gram negatives. So the E. coli and Klebsiella now are usually resistant to the third generation cephalosporins, and what you need is to take them up with carbapenems. However, the carbapenems are also developing more and more resistance, especially with Acinetobacter and Pseudomonas. Vancomycin resistant enterococci are more and more seen. So you see the resistance pattern is also increasing. And so it's very important that we choose our antibiotics very carefully. We get our right cultures, and then only we'll be able to fight out with this infection. So if coming on to the big decision whether to retain or remove an implant, so we'll look at the factors which actually favor retaining an implant. So if, let's say, the infection is an early infection which is happening between the 2 to 4 weeks of surgery, this is the time when the biofilm has not matured up. It is still susceptible, and this is the time it is better to get in. This is called the golden window, to better to get in and debride. At the same time, if your implant is stable, it is a good, let's say, indication for retaining the implant if there is no loosening. If the organism is a highly virulent organism rather than a low virulent indolent organism, then also it is better to go in and debride, because then it can respond better to retention strategies. So it is better to retain the implant at that time. If you have a low virulent organism, then retaining implant is a bigger problem, because then they are difficult to get rid of. If there is good soft tissue coverage, implants can be retained because of good supply. If the spinal stability is quite crucial with the implants in, then it may be difficult to remove the implant, like in a deformity surgery or in an osteotomy where you have put an implant. Then there is no way you can think of removing the implant, because it may be very risky neurologically. At the same time, if the patient is more let's say robust health-wise and has good nutritional status, then probably he'll be able to tolerate a prolonged antibiotic therapy, which is required usually with the implant retention. So the advantages of retaining implant is you can have biomechanical stability, you can hope to get fusion. The surgical trauma probably is reduced because you are removing less, you're exposing less. At the same time, you can have lesser, let's say, economic issues and a faster recovery. So when you want to retain the implant, make sure that when you debride during that procedure, all infected and necrotic tissue is removed, the hematoma is removed, and multiple samples are taken from at least 5 to 6 different sites for being able to get the tissue diagnosis. Tissue diagnosis is the critical most part in these scenarios. At the same time, you must irrigate your wound with high volume, minimum 6 to 9 liters of lavage with antiseptic solutions and one of the best is to use povidone iodine. Wound closure can be primary or it can be over a vac dressing. Antibiotic therapy should be initially an empirical phase, which should be a broad spectrum antibiotic, and followed by, once you get the cultures, you can be more specific with the antibiotic. It is better to use always biofilm active agents like rifampicin if the antibiotic is if the isolate is gram positive, or fluoroquinolones if the isolate is gram negative. So the recommended combinations for the antibiotic is in MRSA, vancomycin plus rifampicin, and for gram negatives, any of the fluoroquinolones like ciprofloxacin or levofloxacin along with the sensitive antibiotic. The key principle is never to use rifampicin as a monotherapy and always ensure adequate drug levels with monitoring. The duration of antibiotic in retention cases, for the first 4 to 6 weeks, you can end up using IV antibiotics. And moment the IV antibiotics stop, you immediately switch to oral biofilm active antibiotics, which means that you combine rifampicin or fluoroquinolones along with your sensitive antibiotic. If in case the infection is quite indolent, then you may need to extend the oral antibiotics to 3 to 6 months. However, if let's say the bacteria is such that it is also resistant to a biofilm forming antibiotic, then you may have to consider suppressive therapy till such time that the fusion occurs and you can remove the implant. The monitoring initially can be more intense, weekly and then fortnightly, and then later on you can sort of increase it to quarterly monitoring as well. The indications for instrumentation removal are when there is a late onset infection, if the infection has come after 6 weeks, or if the isolated organism is multi-drug resistant or a fungal infection or a mycobacterial, then it is better to remove the implant. Or if the implant has loosened up quite a lot, then there is no sense of retaining the implant. Or if you have already tried initially debridements, multiple debridements by retaining implant and it has still not got successful, then ultimately implant removal should be contemplated. This is an algorithm which was proposed by this German group in a paper in 2020. And what they said was that in the early onset, if the implant is stable, it is better to debride and retain with 12 weeks of biofilm active antibiotics. However, if in the early onset the implant is unstable, then you may consider adding and exchanging the implant and then continue on 12 weeks antibiotic. For late onset surgical site infections with implant, if the pathogen is sensitive to bioactive agents, then it is better to exchange the implant and give antibiotics for 12 weeks. However, if the bioactive agents are also not working on this bacteria, then it may require an prolonged therapy, and the target is to do suppression and then remove the implant once the fusion is achieved. The surgical technique is basically careful exposure and sequential removal of the implants, and being very, very careful when you remove these implants. And at the same time, if there is any dead space, to manage them with any local free flap so that there is no dead space. Also, you may end up requiring some cement spacers. And there is a role of antibiotic spacers also in spinal infection management. So what we can do is the local antibiotic spacers can be made according to the type of defect. And you can use antibiotics like vancomycin, gentamicin, or tobramycin. And this increases the local antibiotic concentrations by almost 1,000 times and can help in reducing infection. The antibiotic mixing can be done manually if you want to make a custom made defect filling cement. So what you can do is you can take equal amounts of antibiotic and cement. So if you have a 2 gram antibiotic dose which you are taking, you can initially mix it with 2 gram of cement. And then when you get a 4 gram mixture, you can again mix it with 4 gram of cement, and so on and so forth. And you can get a homogeneous mixture. The usually recommended antibiotics for antibiotic spacers is gentamicin, tobramycin, or a genta and vanco combination. So this is one of our cases wherein the patient had presented with a gunshot injury with colonic injury, and we had done a posterior stabilization with anterior reconstruction. However, he had developed infection because of, I think, the colonic injury, And even after multiple debridements, the infection did not settle. So he was put up with a cement spacer at 8 months post-op. The patient was lost to follow-up for some time, and then he reappeared around 2 years with this sort of scenario wherein the bone had sort of not healed by that time, and he had a discharging sinus. So what we did is we did another spacer along with antibiotic for around 12 weeks. And then once the infection settled down with the fresh spacer and stabilization, we went ahead and did a bone grafting from the anterior approach. And this is his final result. So these antibiotic spacers with stabilization can really help in controlling very difficult infections also. VAC therapy can also help quite a lot in these mechanisms because it helps in reducing edema and helps in hypergranulation. We all understand how it is used. So this is one of our cases wherein the patient had come with a farm injury, and his entire spine was cut into almost second half, and his paraspinal musculature and retroperitoneal fat, everything was exposed. And this was a injury from a tractor, and there was a complete disarticulation. What we had done for this patient is we had done a reconstruction at the tried to close everything. We had, of course, the patient was paralyzed, but we could reconstruct with a cage, and we had closed him up primarily. At the same time, if you can see on the X-ray, we had used antibiotic beads for this patient. However, in spite of giving best antibiotic, the patient developed wound infection around 6 weeks, around 2 weeks of the 2 to 3 weeks of injury, and then we had gone ahead again, put him on debridement and put him on VAC. So these are the type of things which you can use for such difficult injuries and post-op infections as well. Post-op infection with implants is more of a multidisciplinary approach. Not only you are there as a surgeon, but you need to involve your infectious disease specialist, your plastic surgeon, your pain specialist, microbiologist, and nutritionist. Then only we can fight these infections. So key takeaways for us is early recognition of a post-op infection is very important. We need to individualize treatment. Not every patient can be helped by retaining the implant, and not every patient requires removal of implant. So usually early infections will do better by retaining implant. And if it's a late infection or a very low virulent organism or a fastidious fungal infection, then usually a spinal implant needs to be taken out. It's very important to optimize the host to fight this infection, and a multidisciplinary approach is very, very essential. Thank you.
Thank you, Ankur. There's a question in the chat box. Maybe Ankur, you would like to answer. How long will you antibiotic after debridement and fusion?
Yes, so it really depends upon what sort of infection we are dealing with. And it's usually recommended to at least continue with 2 to 4 weeks of IV antibiotics, and then shift over to a bioactive agent along with the antibiotic for around total duration of 12 weeks. But at the same time, I think it will also depend upon the markers which you are doing, your inflammatory markers, and also the clinical response of the patient. So a typical IV therapy for us is anywhere between 3 to 6 weeks, followed by at least 6 weeks of oral therapy combined with a bioactive agent whenever the implant is there. But sometimes you need to extend these to even, I would say, 6 months.
Okay, thanks. Dr. Jhala, do you want to deviate from this, or you also agree with this management of antibiotic after debridement and fusion?
So it depends
We're
whether there
talking
is
about
a
post-op infection.
yeah. So post-op infection is a different compared to when there's instrumentation or there is no instrumentation. Because if it's just a post-op infection, the antibiotic, if you have debrided, antibiotic is going to work very well because there is no biofilm, the instrumentation is not there. So if just a post-op infection with a fusion, then I would cut short, as I said, for 3 weeks of antibiotic and then monitor with the help of the ESR, CRP or inflammatory markers and clinical response, followed by an oral antibiotic for further 3 weeks. So that is what if there is no implant inside.
Yes, I think the critical point is
Thank you.
implant and
In
the
the interest of
implant
time, I
not
think
being there, because the big problem with the implant related infections is the biofilm, and it's something which we need to stress upon a lot, and that is why a longer duration antibiotics required with the instrumented infections.
Okay, thank you. Let me invite Dr. Vijay Anand, who's going to talk on VAC, role of VAC, vacuum assisted closures. Over to you, Dr. Vijay. Stick to time, please. Thank you.
Yes, sir. Thank you. Good evening, sirs, and respected seniors and my dear friends. Good evening, everyone. So my talk would be on role of VAC dressing in postoperative spinal infections. So sorry, my slide is not moving. Give me a moment.
There will be a cursor in the left-hand corner of the screen. You mark that arrow.
Yes, sir. Yeah. Yes, I got it. So, coming out with the introduction, the surgical site infections or potential complications which increase the hospitalization and expenditure. It causes significant morbidity and adversely affect the outcomes. Despite the routine use of prophylactic antibiotics, the literature reports that the surgical site infection incidence is around 0.4 to 20%. And this incidence is higher in cases of instrumented fusions, multi-level surgeries, and surgeries that require longer duration. So coming into the management of surgical site infections, the standard treatment is radical wound debridement, irrigation, and IV antibiotics as discussed by our previous speakers, and various adjuvants like implant revision, antibiotic impregnated cement beads, or irrigation suction systems, and delayed primary closure systems are other reported techniques. However, despite our best efforts, infection may still persist. So that's where VAC comes into play. VAC is nothing but a type of a negative pressure wound therapy. The idea of using suction to treat the wounds is not something new. It in fact dates back to the ancient practices like cupping. So the use of foam dressings and negative pressure to treat war wounds has been used first by Dr. Neil Bogotnow in 1985. The modern VAC therapy, the brand name, was pioneered and popularized by the US surgeon Dr. Louis Argenta and bioengineer Dr. Michael. They first published their results in 1997, and since then, VAC has been used worldwide very widely. So, coming out to the mechanism of action, so there is various ways by which the VAC works. One is macro deformation. The suction physically draws the wound edges together, so the wound shrinks. And at microscopic level, the foam stretches the cells, stimulates and divides and proliferate, and increasing the granulation tissue formation. It removes the edema and infectious exudate. These exudate inhibits the mitosis and protein and fibrogen collagen synthesis, and it increases the blood supply and improves the antibiotic delivery and lowers the bacterial load. And also it creates a closed, warm and moist environment and prevents any further external contamination. So coming out to the indications, the primary indication is in postoperative surgical site infection, and it can be used in exposed spinal hardware and in wound dehiscence and necrosis. And it can be used to facilitate closure in large soft tissue defects or in failed primary closure. And most recently, it is used prophylactically in high-risk patients where the VAC is applied immediately after a clean surgical wound to a closed intact incision to prevent surgical site infections and wound related complications. So before going on to the technique, there are certain prerequisites. So VAC is, you should remember that VAC is not an adjuvant to debridement, and it's an adjuvant to debridement and not an alternative. So a thorough debridement is mandatory. You have to remove all the necrotic tissues. You have to irrigate the wound, make sure that the wound is red, healthy, and you have to also make sure that the implants are not used. Loose implants and infection does not go well. So you have to change the screws and extend the instrumentation if required and make sure the construct is strong enough. And the next step is to achieve a thorough hemostasis. So in presence of bleeding wounds, the VAC should not be applied. And if despite your best efforts, still you are not able to achieve a good hemostasis, you have to postpone the procedure and then you pack the wound and then come back after 48 hours to apply the VAC. And also be sure that there are no CSF leaks, which can be detrimental to the patient. So coming on to the technique per se, the image which you see on the left is the VAC apparatus, which has a canister on the other side. And on the right, you see a polyurethane foam, a black foam, and a tubing over which the trackpad is there. So this polyurethane foam is usually placed over the wound, but it should not be directly placed over the dura because it can abrade and cause injury to the dura. Whenever it needs to be placed over the dura, a white foam made of polyvinyl alcohol can be used. But in our practice, we use gelanate over the dura, and then over that we place the polyurethane foam. And after placing the polyurethane foam, we usually apply the adhesive tape and make sure that the seal is very tight, and 2 centimeter incision is made over the foam, and the trackpad is attached and connected to the VAC apparatus. So coming on to the pressure settings, the pressure settings can vary depending upon whether the dura is exposed or not. When the dura is exposed, the pressure has to be maintained in a low continuous suction. Usually the pressure setting has to be kept in 50 to 75 mmHg. Whenever you place in high intensity or a cyclical mode, it can cause a headache to the patient. So be very cautious about that. Whereas in case of superficial wound or over the fascia and muscles, the pressure can be kept at 125 mmHg, and it can be placed even in intermittent mode to provide to facilitate faster granulation tissues. So coming on to the frequency of the cycles, literature reports that the VAC dressing needs to be changed in around 3 to 7 days in case of deep surgical site and contaminated wounds, whereas in superficial wounds, it can be retained up to 7 to 10 days. And when you remove the wound, you put saline for 10 minutes, and then so that the foam will be soaked and it will be easy to remove it. So be sure that you remove all the particles of foam, because that can be a source of persistent infection. Every time you open, you debride, curate, and make sure the wound is healthy, and take samples for culture. And average of around 2.5 times of VAC therapy will be required as per the meta-analysis. So what is the endpoint of VAC? So the wound has to be healthy, granulating, and there has to be no slough, and the implant has to be covered by a good granulation tissue. The cultures has to be negative, the CRP and ESR in a declining trend, and there has to be absence of fever or sepsis. It usually takes around 2 to 3 weeks in deep surgical site infection for the wound to become healthy. If it is an early surgical site infection, 7 to 14 days of therapy may be adequate. As per the meta-analysis, a mean of around 17.45 days is required for the wound to become healthy. And when the wound is healthy, a delayed primary closure can be done. If there is a defect is quite wide enough, a flap cover may be considered. So what is the success rate with the VAC? VAC offers a good success rate, and it helps in retaining implants and prevents sepsis and mortality. So as per the recent meta-analysis of 15 studies, so the infection recurrence rate is around 2%, and reoperation rate for internal fixation is around only 4%. So the parameters that was related to repeat VAC procedures was MRSA and polybacterial infections. So it is not without limitations or contraindications. The major limitation is active uncontrolled bleeding and presence of untreated osteomyelitis or necrotic tissues, or any malignant tissues. Also be sure that the dura is intact and there is no CSF leak present. So coming on to the complications, hemorrhage is the most common complication that can happen. Even a small muscular bleeding can result in a huge hemorrhage, and like the one in the picture, patient can end up having 700 ml of blood loss within a span of 6 hours if you don't ensure hemostasis. The next common complications can be headaches, and if there is a case of durotomy repairs, there is a possibility of CSF leak, which has to be kept in mind. And there can be frequent alarms due to leak or blockage of the tube, which may require change of the dressing. So another controversy in VAC is whether VAC can be applied over the exposed dura or not. Initially, there was a hindrance to use the VAC in presence of exposed dura. However, recent publications have emphasized the safety of it. Lee et al. Have successfully used the VAC in presence of dura without any adverse effect of CSF leakage or spinal cord injury. Recently, even Ridvan et al. Have reported in the 10 cases where VAC was applied, in cases where dura was repaired and there was no CSF related complications. So this is a case example where a 62-year-old male with a known case of chronic kidney disease on hemodialysis for thrice a week. He was operated elsewhere where they have done an L2-3 fusion, and post-surgery, 4 months later, he presented to us with increased pain and fever of 2 weeks duration. So we did an MRI, and this was his MRI imaging, which showed that there is a deep surgical site infection at L3 region with the collection in the postoperative area. So we decided to do a debridement, and when we opened the wound, this was the picture. It was full of slough and necrotic tissues and looking very unhealthy. On seeing this picture, you are sure that this wound is not going to become all right in a single stage of debridement. So you make up your mind to do a good debridement and apply the VAC. So we did a good debridement. We took some samples for culture, which came out to be negative. After extending the revising the instruments and extending the instrumentation to one level above and below, we did the decompression. We went into the disc space. We removed all the infected bone fragments. We did a thorough irrigation of the wound. We debrided to the extent the wound is healthy and red enough, and then we applied the VAC. So the patient underwent 3 cycles of VAC, and then sequentially the wound continued to improve. After 22 days on 3 cycles of VAC, the wound was healthy enough, and we did a primary closure. So at 6 months follow-up and 2 years follow-up, the X-rays shows a good consolidation of the fusion mass, and wound has healed completely with no recurrence of infection. And finally, patient underwent renal transplant as well. So to summarize, the VAC system is a very valuable adjunct in managing resistant post-operative spinal infections. Along with the thorough debridement and antibiotics, it provides a very good success rate. It most importantly, it allows for retention of instrumentation and eradication of infection. It reduces the morbidity and helps prevent sepsis and mortality. It is safe and does not increase the chances of CSF leak, and it is very reliable and easy to use. Thank you.
Thank you, Dr. Vijay. Is there any question for Vijay? Okay. So Vijay, let me ask a question.
Yes, sir.
In case you have a deep surgical site infection and you have taken a decision on debriding it, at what juncture do you decide if this patient has to be vacced, or you can do it you can close it after a thorough debridement?
So we don't go by just the wound alone. It is a combination of factors like how long the infection has been, what was the patient treated for, whether the patient is, what is the comorbidities, what was the infection, what was the resistance pattern. All those things come into play. If there is an infection has been there for 4 months time, and then we are going to think in terms of VAC, because we don't want to do a primary closure and with a single debridement, because the infection has been there for 4 months time, the recurrence rate is high. And also when there is a polybacterial infection or there is a resistant organism, then the chances of recurrence are still high.
About immediate post-op, you have a surgical site infection and you take a decision on debridement.
Okay. So in the immediate post-operative infection, so if it is less than 1 month time and the tissues are looking good after debridement, we would aim for a primary closure of the wound.
Okay, thank you.
However, if the wound is very bad at presentation, the implants were loosened and we have to revise the implants, patient has comorbidity, patient has high fever and is at the verge of developing a sepsis, then we would prefer to do a VAC therapy and then delay the primary closure after, and only when the wound is healthy, we would do that. It's a combination of factors, not just the wound alone, which we decide upon.
Pankaj.
There's a question for you, Dr. Yes, sir.
Apart from the VAC is an excellent thing, I think, for apart from a single level disc infection, I put it for everywhere. But important part of the debridement is, I think, taking out the small pieces of bone graft which we put it in the in the lateral gutters. So that are the main culprits. Unless until you keep taking out all that bone, the infection doesn't go. And I use a pulse lavage, which is for knee and to do a debridement in the first stage. So it cleans the area very well, and removing the rod and using the pulse lavage around the screw heads and putting a lot of betadine for some time, it helps clean the wound very well. And personally, we use a plastic surgery team along with us because that tissue handling is much better. And the VAC is an excellent thing. Thank you.
Okay. Thank you, sir. There's a question for you, Vijay. Hang
Yes,
in
sir.
there. Advise back application in active dural.
Pardon,
So
sir,
there is
your
a
voice is breaking. I couldn't
site
get you.
infection with some active dural leak. Would you advise back?
So the vac should not be applied in presence of an active CSF leak. You have to first address the CSF leak. You have to make sure you try to suture it off. You put up seal, you put up Duragen, you pack it up for a few days time. You don't close the wound if there is an infection. You just try to pack it as much as possible, and then you try to reopen it after 5 days and see how the wound is. And then only when there is no active CSF leak, then you can go on to put a vac, and you'll be very clear about that, because CSF leak, if it starts draining, it can be very profuse and patient can land up in serious problems.
Thank you. Let's move on to now case discussions. The first case would be by Dr. Naresh Babu.
Yeah. Are my slides up, Pankaj?
Yes.
Thank you. So this is a 40-year-old female patient who had this problem, and she has got a L5S1 disc herniation. And then she underwent a microdiscectomy for L5S1. On post-op day 5, she had a recurrence of leg pain and again. So she again underwent a recurrent revision discectomy on day 5. So the leg pain has subsided, and then she presented on 5 days after the second surgery of a revision discectomy with severe fever, chills, rigors, and wound discharge. So this all happened before, and the wound was managed with regular dressings, debridement, and was kept on working with VAC dressings. This was the scenario when the patient presented before the VAC dressings, and this is the wound scenario which is presenting out. So she has got blood culture, no bacterial growth was seen, and the tissue from the wound has grown E. coli sensitive to tetracycline. She started on tetracycline and debridement for 2 weeks of VAC dressings was done, and this is the end of the 2 weeks. This is the situation when she presented to us with pain and persistent wound discharge and open wound and some disc space infection. So this is where so we got stuck in. I think this is open for discussion. Pankaj, you can lead the discussion for that.
So I understand there was a discectomy done sometime back.
Twice. So
Twice.
within a gap of 5 days, discectomy done, and she had a recurrence of leg pain. Revision discectomy done after 5 days, and after 5 days, the wound started soaking with discharge, and then patient was put on VAC dressings for 2 weeks. At the end of the 2 weeks, she presents with this condition of the wound, still not completely healed, and there is a disc space infection at L5S1, and also there are some signal changes happening at L4 vertebral body and some changes at the superior segment as well.
Does she have systemic signs of infection?
Yeah, she had fever, chills, rigors before.
But not now.
Before putting that, not now. Now she has a lot of back pain.
Okay.
Yeah. And wound is not healing.
Okay. So, do we know her blood markers right now? What are the blood markers like?
Yeah, blood markers is infected, and the tissue grown E. coli sensitive to tetracycline. So she's on antibiotics now. So now the two issues for her, one is the disc space infection, which is persistent, and wound problems. So how to tackle with the wound infection and also the disc space infection? Maybe we can start with Vijay.
Dr. Akur, would you like to?
Yeah.
Vijay still here?
Sure.
Yes,
So
I'm here, sir.
You can take it forward. What would you do in this patient? would you like some more investigations, or what is your plan?
So how is the pain response after this treatment with the VAC, and after 2 weeks the fever is subsided and the pain is subsided? How is it?
Pain still there.
Pain is still there.
Painful.
Going by significant pain and the disc space infection, they're also looking like the disc space shows a discal abscess. There is a hyperintensity, possible discal abscess as well, and if the pain is significant and she's not able to move, then I would again go in and then do a debridement and stabilize the segment as well, so that and continue VAC therapy for 1 or 2 cycles at least, and then continue the antibiotic, and then go have a second look, and then go on. If the disc space looks okay, then I may graft it or put a cage at the second setting.
Okay.
I
So I think we have
whatever-
two situations here: a discitis as well as a infected open wound.
Exactly.
Yeah.
The two situations.
Yeah. So Ankur, would you like to instrument it, stabilize it
So
now,
before-
or what is your plan?
Before I go on to be surgically aggressive, I think one thing which I'm going to definitely do is add on to the antibiotic. And my reasons are as straightforward as this. The TG cycline is a very bacteriostatic antibiotic. It's not something which is quite effective, especially for something like E. coli. It's a even though the sensitivity may have said that, but it's not a very good antibiotic. So I'm going to add on more antibiotics for her. The very fact that even though the infection was detected so early, we're in such an early post-op period without any implant, still the vertebral body has gone on to get infected. There is something major problem with the let's say antibiotic which is acting, and also the immunity. So these two things have to be taken care of, because even if we go ahead and instrument and graft and everything, the infection is not coming under control. That's for sure. Otherwise, I agree with Vijay. We can go ahead, debride again, get fresh samples, again send them for sensitivity, and take it from there. Putting implant right now is again, a double-edged sword. So I would try to see how uncomfortable or comfortable she is, in bed. If the pain is not so bad, I may be tempted to not instrument her right away and wait for some time, get my antibiotic correct, and then maybe little later I may like to go in.
The Vasu's
Patients here, and one of the surgeon wants to be aggressive. He wants to go debride the disc and do instrumentation, while Ankur would like to take care of infection, discitis by antibiotic, and wait for the wound to heal. Yeah. Okay, Dr. Jhala, how would you manage this case? Would you approach this disc through some other approach, or is it going to be the same?
Yeah, the same thing because I would go from a lateral approach, and because it is very difficult to go because it's already twice operated. The wound does not look good, so that I can go through the same approach. So I will go from the lateral approach and go into the disc, clear and wash out the disc space, because that's also the primary source of infection which is there. Because from that it might have started, it's a postoperative discitis, because there was a hematoma there and plate changes might be there inside. So I would go from a lateral approach and then do a thorough debridement from directly into the disc base, because all posterior things are going to be taken care of by the VAC and all that things. So instrumentation I would not do at present, because it does not look to go for instrumentation. But with either a transcambin approach or a lateral approach, I'll go put an endoscope, wash out the disc space. Maybe you can put in a few bone graft chips also, if at all, if you feel that it is, or you can just have a suction irrigation capped inside. Till the time that is also one of the possibility. You go from both the sides, put the suction irrigation, so the disc is also washed out every time. So that is one of the way that I may go from a clean space rather than going through the same wound.
Dr. Basu, I have a quick question to you. So I understand this patient is improving clinically with antibiotics. We have organism which has been detected. Antibiotic also we are aware, and her obviously her general condition and other systemic symptoms are getting better. Would you still approach aggressively the disc, or would you rather continue the antibiotic?
So I would look at this problem as
As
Naresh correctly pointed out. first the wound part, and second is the discitis part. And the discitis part, my judgment would be dependent on whether there is a significant bone loss or erosion in the end plates, which is very well picked up on a CT scan. I do CT scans in all my patients of suspected discitis. And if there is
Here,
an
MRI,
erosion,
you can see end plates are very regular, sir.
if the CT scan does show end plate irregularities and the patient is typically having a lot of pain, especially when turning in bed or when trying to get up, then for pain relief, I do a MIS fixation. And as this wound is central, I think I can get away with a lateral 4 MIS screws and take care of the wound management. Of course, antibiotics is extremely important. Now, in my personal experience, I have not had to go in with a TLIF or an interbody work, because most of them, I mean, if not all of them, have healed interbody with bone growth. And a lateral approach or an anterior approach is always there if at all the disc space needs to be debrided, or if a anterior column support needs to be put in. But wound management should go on peripasal with VAC and antibiotics.
Would you like to get a dynamic X-rays done in this patient if instability is your concern here?
Most of these patients are too painful for getting up and standing up and flex and extend. So I rely a lot on their pain while turning in bed or while trying to get up from a lying down position, as well as a CT scan showing erosions in the end plates. So if that is there, I would definitely fix it. Otherwise, these patients would never get up from bed because they're extremely painful. And until unless they are mobile, I do not think the wound healing would be easier. If they are mobile, if their vascularity increases, their wound healing would increase.
Okay, so let's see what Daresh, what did you do?
Yeah. So I have the same thoughts like what you guys have been discussing. My initial problem is the wound and then the disc space infection. If the same patient without this kind of wound, my first choice will be to re-explore, like what Vijay said, explore and debride thoroughly, some kind of a radicular debridement, and then put screws if possible, and antibiotics and graft. But here the situation is the wound takes priority. So like Jhala sir said, so we had this approach of transcambion approach, wherein so this is the wound which we have thought of, and then we entered from one side, and also put a cannula on the opposite side, so that we had a connection between the disc space. Without opening the wound, we wanted to debride the disc space. So this disc space debridement has been done bilaterally on both sides. It's bilateral biportal kind of approach, which we went into the disc and without disturbing the main wound, and we were able to thoroughly debride the disc. For that, I think we need these kind of special equipments which can actually help you to do a radical debride. The success of this procedure depends on how radically you are able to debride. So these set comes up with a kind of expandable shavers, wherein you can expand and clean the disc space. And there is something called flexible curate, which grabs the disc and which comes out. And there is a articulating curate. This articulating curate actually curates the end plate effectively. So this is how we actually do. And I think all the steps like Jala sir has caught my mind. And the same thing we have already done the biportal endoscopy, where you put the two scopes, right and left, operating from the both sides. And we are able to do a thorough end plate debridement, and we got the tissue out of it. And this all CM guided without disturbing the main wound. And you can see that the amount of disc material we can get out of it is significant, quite significant. It's just not taking the biopsy, but doing a radical debridement. And we start irrigating from one side. You can see the fluid coming out from the opposite side. So we established the disc washout, like extensive disc washout has been done. We repeated from the opposite side, and we washed from the left side. Then you can see the material coming out from the right side. So thorough disc wash, thorough end plate debridement, and tissue sample again taken for the culture and sensitivity. And this is how we are able to do excellent end plate debridement by using an angulating curate. So this curate angulates the end plates, and this flexible curate takes off the disc from the disc space. And we use this antibiotic beads through the same cannula. We pass the antibiotic beads and pack the disc space extensively. And we also use the same scope to put the antibiotic beads under the skin. And we applied this shoelace technique of closing the wound, and gradually we tighten the wound, and we're able to get a decent. This is how we gradually do it on a 2 to 3 days basis. Why gradually the wound gets closed, and then that's how we ended up with the excellent wound closure without disturbing the thing. So we are able to achieve the disc space clearance at the same time wound coverage without opening the wound. So this concept of new endoscopic approaches, wherein we can approach the disc space and even the epidural space without opening the wound. Even you can try with this biportal technique here and enter into the epidural space and also wash out if there is a epidural collection is there. I think it's promising. This is how we had all the beads applied. So patient is significantly there is a reduction in the pain, and wound has also healed. We're just following up the patient. If the patient still has some back pain, I can apply percute screws. Like Basu sir said, we can apply percute screws for this patient. Yeah, that's the case.
Thank you, Dr. Naresh. Excellent.
Well done, Naresh.
Let's move on.
Thank you, sir. Thank you, sir.
Dr.
Naresh, very nicely done. If I can ask, which cement we have used here?
These are the cement. This is absorbable things, na? So PMMA beads. These are all absorbable.
Yeah.
It's not the cement.
Okay, so this
They
is
are antibiotic beads.
Antibiotic beads which are
Yes.
absorbable.
okay. So these are calcium phosphate.
Something like stimulant. Something.
Stimulant, exactly.
This
Stimulant.
is stimulant. This is stimulant.
Yeah.
Vancomycin. We mix the vancomycin with this one.
Okay.
Let's go to the next case. Who's next in line? Vikas, are you ready with your case?
I'm ready with my case.
Okay, great.
Screen visible, sir?
No, not yet. Yeah.
So thanks ASSI study group and thanks Dr. Basu sir for giving me this opportunity. So let's go this 48-year-old female patient with tandem stenosis presented to us with neurogenic claudication, tingling, numbness, imbalance, and while walking and difficulty in performing fine hand activities for the past 2 months with multiple comorbidities, which includes hypertension, IHT, and COPD. And she is also obese on examination, having widely cared and typical signs of myelopathy with no gross motor neural deficits and bilateral severe ONEs. So this is the case which we presented to us with a gap of 4 days. We went ahead and did cervical as well as lumbar surgery. So following 3 weeks follow-up, she presented to us with repeated showcase of the wound, and aspiration showed no growth culture, and we started on broad spectrum antibiotics routinely with repeated aspirations. The CRP level, which was higher side around 17, which came down to 7 and went on. So this is how she's clinically standing post all the debridement, how obese she is. Then the problem started 2 months follow-up. She is presented to us with severe non-remitting pain of both lower limbs, not responding to any of the oral medications, urinary retention, and weakness and swelling of the left lower limb with left EHL ADF around 2 to 3/5 with loss of left ankle gel. So this is how it is. And This was her condition, and her HB, CRP levels and albumin were on the lower side, and CRP was higher. And urine culture showed Klebsiella pneumonia and wound aspirate, which as you can see in the collection, which was there in the MRI. So it came out to be staph hemolyticus. So I would ask the panel for this discussion, what would be the next based on this MRI, X-rays, and this amount of comorbidities.
Because I understand this patient didn't have any neurological deficit to begin with.
No, sir. No neurological deficit beginning with. So post-operatively, her ADF and EHL was around 4/5. And this is the presenting complaints 2 months follow-up.
So she came with new weakness at 2 months follow-up.
Yeah, new weakness, urinary retention, severe both lower limbs pain, not responding to any of the oral medications. And those MRI and dynamic
Okay.
dynamic X-rays and MRI, this is what she is it. And you can see the gluteal folds. She's already started having fungal lesions.
So there are multiple issues here. I understand the
Yeah.
patient, the hemoglobin is low. She has got skin issues, local skin issues. Plus, she has got a big collection in the subcutaneous plane, and now the deficit which has developed.
Yes, sir.
Let me ask Naresh Babu. Naresh, how would you proceed with this case? What did that collection grow, Vikas?
Yeah, I mentioned, sir, Staphylococcus hemolyticus. Wound aspirate.
Okay.
The
It was
collection which
sensitive
was there.
to, there was
Yeah, it was sensitive to phosphomycin and tigecycline initially.
Because what do you think is the reason for
so Naresh.
neurological deficit? What is the reason for the neurological deficit?
Sir, maybe the acute infection which is caused by the urine, which could usually will be the causes in most of the case without any compression on the MRI. The new onset of infection, especially of the urine, in this comorbid patient, and low albumin, anemic patient. So that would be the reason.
A deficit, neurological deficit.
Yes,
is
sir.
Compression yours.
Yeah,
Do
there's
Do you
no,
have better here?
there was
Do you
no
have better
compression.
MRI here?
So is it not the CSF? That's what I want to say. Is not the CSF?
No, sir.
Yeah, it's a wound collection. Okay.
Yes, sir.
Yeah. So that now this is more complicated than my case, where I
Yes.
have only wound issues and disc space infection. Here the wound issues, disc space infection, and also neurological deficit. So she need to be improved on the hemoglobin status,
Yes.
the anesthetic fitness. Once she improves on anesthetic fitness, then we can plan some aggressive things. Meanwhile, this abscess can be drained through the approach what I have mentioned. So we can approach the disc space and also the subcutaneous space with cannulas, and then thoroughly debride and decompress the disc space from the front. That will significantly reduce our back pain. Meanwhile, if the general condition improves and hemoglobin improves, then I need to plan into second stage of a thorough decompression from the posterior. So at this stage, I'm not keen to take her for a second debridement because she may not be able to
Yes.
be anesthetically fit for the same procedure. Yeah.
Okay, sir. So let me go ahead again because of the medical comorbidities, and she's obviously unfit for any surgical procedure at moment due to all these conditions. Again, we went ahead. We started on antibiotics, albumin correction, anemia correction, and DVT prophylaxis and physiotherapy along with that. So this again, as I mentioned about all the challenges which she was facing, that is the reason we took up this conservative management. So again, 3 to 5 months post 1 month, we continued with the conservative management. Her HP was on the lower side. Again, we took a hematologist opinion. which bone marrow biopsy showed iron deficiency anemia, and gradually by 3 to 5 months follow-up, the CRP started to come down. And at 7 month, this was her presentation. She was walking with walker. All the scar is healed, non-tender, albumin, CRP, and HbS are all within normal limits. Then again at 10 months, we got a CT scan done, which showed the implant failure, which was there previously with vacuum signs around, and all the HB and CRP levels were fine, and she was walking with the help of walker. And this 1.5 to almost 1.9 years follow-up. There was no change when we saw at 2 to 3 months post-operatively. It was the same, and she was walking comfortably with walker without any pain or the back or any sorts of issues. Then the issue started 2 years post-surgery. Back pain radiating to both lower limbs, aggravating one, and trying to sit down bedridden for the last 15 days, and severe tenderness over the wound site. With obviously the weakness was there as mentioned previously, with little more proximal, more weaker this time, and the CRP and the albumin wells at this presenting stage. So this is what the X-rays look like, and with the edematous changes around the L5 and S1, and these are the CT scans which was there.
Yeah. Now
So
there is no infection, isn't it?
yeah,
Infection
so
is
now no sir. So this is what he's are presenting complaint.
as of now she is free of infection.
Yeah.
2 years, and this is like degenerative kind of adjacent segment degeneration. How did her neurology improve? Any
So
procedure was done?
no, nothing, no procedure was done, sir. Just with the physiotherapy and the exercises, once all her infective parameters started coming down, so it gradually improved. And of course, the weakness of the foot, which was persistent throughout until even at 2 years follow-up. So
Yeah,
this was
I think
the,
it's like an adult spinal deformity now. It's no more an infection. We have to
but but
treat
the,
it like adult spinal deformity. We have
and there is some intensity changes which was noted, also signal intensity changes noted, the L5S1 also, as you can see in
yeah.
the MRI, as well as this is the CT scans.
Are the news changes or the same changes persisting from before?
No, that was the changes were not there in the previous MRI. These were the new changes which was in present.
If there are new changes and you are suspecting recurrence of infection, I think we should get the tissue sample from the same, the new high signal area, and then go about it. But looks like the MRI and the CT scans looks like patient has got extensive degenerative disease, and
Okay.
different segments and then end plates and other things above are completely degenerated, and there is vacuum sign formation. She's like a full-blown adult spinal deformity kind of a scenario. Post fixation. But if you still have if the markers are elevated and the signs of infection, then I try to get a tissue sample from the disc space, maybe endoscopically or transcameron or percutaneous, whatever the way I can do, and make sure that that's not an infection, and then treat the condition. If there's infection, that scenario completely changes again.
Okay, sir. So what we did in this case, again, we admitted her preoperatively. We stabilized her with the, all the medical issues which she had. So we extended the fusion, and the wound culture showed E. coli, and we started on Murinact and Lyotas, and gradually the CRP levels, the infective parameters, which came down. Then 3 weeks post-op, this is the condition of the patient. As you can see, serous discharge. This was the condition of the wound, as you can see in the video also. So now what next? What would be the ideal next stage of management in this case?
So now
Conceptual?
it's pain. No pain is not. It's
No,
only
no pain, no pain.
management. Now
No.
it's only wound management, and you know the bug, and you know how to deal with it. I think we have to do what Vijayanand has said in this case. Try
Yes.
vac, and try to get the infection control and wound management.
Yeah,
Because
the same thing we counseled the patient as well as the patient attenders regarding the need of vac for the wound and about this stage, and the patient again did not follow it up as per our advised, and they continued to go ahead with the regular dressing in spite of our advice of having a vac dressing. And this is what is the wound of repeated dressing over the past 1 month, which she underwent. And almost this is the last image is the which was taken 3 days before.
yes,
So this is
that's
the condition of the present wound, and she's continued been doing regular dressing for this patient. So this is how she is now, at least she's able to stand, walk a few steps with walker support. Thank you, everyone.
Thank you, Vikas, for an interesting case. Do we have questions here? There's no. Dr. Jhala is still around. Okay. So, Dr. Jhala, do you think this was an ideal case for going anterior? Because I feel the segment which was instrumented to begin with was also unstable, and that's why there was a lot of stenosis happening at those levels in the post-op time. So, do you think going
I
anterior?
absolutely agree that I would have gone anterior right on the first time also, because that will stabilize the step. Unless you stabilize, the screws were loose at L4. I could see that
Yes.
on the X-rays also they were loose, and it was all unstable. And because of instability, there might be. This is what my anticipation is, that maybe a neuro deficit because of that instability also. So stabilization was a must. So either you can go anterior, or the thing which was done after 2 years, I would have done the same thing. Maybe after, if the patient was okay after all the albumin and hemoglobin and everything was corrected earlier. So once everything was stabilized, I would have done the same thing earlier. So I would have just bought some 1 year of the patient.
And obviously the chances of infections are also very low in anterior surgery.
Yes, 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 definitely.
anterior. You mean Olive, sir?
Yeah, Olive.
Okay. Dr. Basu, any comments from you?
I mean, it's a difficult, medically very challenging patient, 125 kilos weight, on bed for nearly 2 years. And our anesthesia team was very upset whenever we were trying to push through any surgical maneuvers. They were very, very kind of unwilling to go in for long procedures because we quoted a mortality rate of 10%. We know that these patients have so much of comorbidities, and you can lose them. Hence the delay, and hence she was lost to follow up on multiple times. And ultimately, at least at the end of 2 years, she's having a good wound, and I'm sure this is going to fail. So I'm on the process of slowly and steadily trying to convince her for an anterior support at least, because this is not going to stay unless we give an anterior support. So let's see if the patient and the anesthesiologist agrees for this or not. Because she's still with at least I think she's been to the OT for 5 to 6 times in the last 2 years. Extremely difficult case.
That
Agree.
K-lifts will support these things, na, sir? Jhala, sir. Percutaneous K-lift kind of a thing where you don't expose the skin and wounds and then stabilize the anterior column by putting.
This Dr. Basu's was a different case, but yours was an ideal case for the anterior. That, as I said, that endoscopic debridement would
Support.
have done that. That's what.
For the structural support I'm talking.
But K-lift will not give a structural support because you see there is a lot of end plate which are eroded. You cannot put a metal inside. You don't have a good posterior support. Then you have to additionally have a posterior support also.
Yeah.
So if you are as well going for a posterior support, why not go from back to the front rather than this thing, or go only anterior, or go only anterior.
I will try to get an anterior support at least to protect the screws from coming out, because I'm sure they're going to come off at some point in time.
Thank you, everyone. It was an excellent talk. It was very interactive as well. Nima, are there any questions in the chat box? I can't see any new questions coming up.
Not new questions right now, sir.
Okay. I would thank everyone, Professor Basu, Dr. Jhala, Dr. Babu, and I can see Dr. Chahal also. And I thank all the speakers, Dr. Vijay, Ankur.
Yeah. Rajshekhar sir had to leave because he has.
Yeah, he had to leave early. So I think with this, we conclude this session. Thanks everyone for their time. And
Thank you, everyone. Good night.
Thank you, everyone.
Good night. Good night, everybody.
Good night.
Thank you.